time frame for the Commission to be able to release this transparency tool in terms of finances. And it's very hard to say. Our hope was actually to have it done by March. But given that some of the financial reporting that is available currently is really unreliable, it's going to take us a little bit more time. But our hope would be in the next 3 to 6 months is that we would have that. So one thing I wanted to share with you is this work on our fiscal transparency. We are doing a number of things in terms of our research and evaluation agenda. One of the questions in the packet, the Commission currently has a project underway on children's and youth crisis services. We've adopted a project on mental health in the schools, mental health and criminal justice. Part of our fiscal transparency is looking at reversion policy, and we're looking at the state's and the county's issue resolution process. This is part of our broader agenda at having the Commission drill down on topics of high-level interest in terms of policy and practice, and really be able to do the detailed oversight and accountability in terms of the systems that are in place, how well they're working, how well they're not working. As part of that, last year the Commission issued regulations, something that the legislature authorized us to do, and we are working with the counties and providers to really operationalize those. Currently, they require, beginning in 2017, the counties to provide detailed reporting on who is served and the kinds of services they've received, time to services, and different data points along those lines. As we've worked with the counties, we're finding a number of challenges in gathering these data in a way that are useful. And so we met in Sacramento and in Oakland. We're meeting in Los Angeles and actually in Murphy's, if you're interested in joining us in Murphy's, to really talk about how these regulations will work in terms of allowing us to answer some of the basic questions, including who is served, how many female veterans are served by county, by program, how many children are served, breakdowns by race, ethnicity, language, gender, sexuality. It's going to take some time, but as part of our broad effort to really understand what's happening in terms of California's mental health system, we're putting in place these kinds of structures. Item 2 in your packet is about triage. I'm happy to talk generally about all the things we're doing, or stop there. And
before we do that, I'd like to see if there's anything from Finance on this issue and if the committee members have any questions. So thank you, sir. Anything from Finance on the overview? Thank you. Any questions from members of the committee on the overview? Any public comment on the overview? Seeing none, please, sir, continue into the triage.
Thank you. So triage is one of the core components, so it's hard for me to do the overview without talking about triage. The legislature has provided the Commission with $32 million a year that we allocate through a competitive grants program to counties, and it is designed to support mental health navigators and other strategies to help people who are in crisis. It puts people in hospitals and homeless shelters, clinics, and jails to really help people who come into those venues who need mental health care and services. The latest reports from the county from the first quarter of this year indicate that the funds that have been allocated to about 24 counties, as reflected in your analysis, would be able to support hiring a little over 500 people in those positions. Part of the funds under SB 82, came to the Commission to support hiring people. Some funds went to other state entities to support some infrastructure. Our current report show that there's about two-thirds, about 325 of those 514 positions have been filled. There have been some very significant challenges. The largest are in Los Angeles and Orange County. Los Angeles because of its size, but also they got a late start in terms of getting approval from their Board of Supervisors to get going, so there's been a lag on their part. In the case of Orange County, there's some contracting challenges, so those together are about 100, so that would bring us up to 80 or 85% of those positions as Orange County and LA work through some of those issues. Part of the reason in the delay in hiring some of these positions is they're just really tough positions to fill. These are jobs working evenings and weekends and holidays, serving some of the most difficult people to serve in terms of they're having a crisis, particularly in our rural communities. So the counties have faced turnover. They face challenges in getting the right civil service position. We're not finding any big structural delays. What we're finding is very reasonable kinds of challenges that counties are working through. One of the things that we've been focused on at the outset of the triage programs was really our launch and our ability to provide technical assistance in terms of setting up some of these programs. We're transitioning from technical assistance from a detailed technical perspective to more of a peer-to-peer process where we're encouraging counties to develop the capacity for continuous improvement. We're starting to do site visits. And the intention there is that as counties that have these funds learn lessons, we want them to help share those lessons with each other and also share them with counties who didn't receive funding through this round of grants. The idea is that this is a pilot program, that we're experimenting, we're trying some new things, and we want the lessons to go beyond just the dollars. So we're working with the counties. We're starting to develop the capacity to create venues where there's more peer-to-peer lesson sharing, there's more peer-to-peer learning. We can capture some of those stories and disseminate information on triage to the other counties. Our hope is that the triage program continues and we can issue a new round of RFPs in the future so that what this limited pool of dollars allows us to do is to support the ability of the counties to get better at responding to people who have crises, particularly in keeping them out of the prison system, keeping them out of hospitalization if that's inappropriate, supporting their ability to get high-quality services in a very fast and effective manner. Any questions on triage?
Anything from finance on the triage presentation? Anything from the committee members? Just one question. You described the difficulty in filling the positions. Can you say what skill level or experience level does one have to be in this position?
Many of these positions are peers, and by design, counties are hiring people who have mental health experience to be peer navigators, for example. And in some instances, that's been a challenge in terms of working with some of the venues where these folks would work, because there isn't necessarily the comfort level in those to find a space in a hospital emergency room where a mental health peer worker could have a desk, right? ERs are crowded by nature, and so that's been a challenge. It hasn't necessarily been sort of the job classification is what we've heard from counties. It's the problem. It's more of just the availability of people to do these jobs, because often it's, the best example I heard is we're looking for someone in a rural county with very limited pay who will work nights, weekends, and holidays. And those are just not the first jobs on everybody's list.
Understood. Thank you. Is there any public comment on this item? Seeing none, we will move on to issue number 3. Innovation Plan Reviews Budget Change Proposal.
So so innovation is the next largest piece of the Commission's work, in the sense that the legislature authorized the Commission to review and approve innovation plans for the counties. And so currently, counties provide us with their innovation plans, and we have limited staff who review really for compliance with minimum standards under the law. And it's a relatively limited process, and we've had one person who's been able to do that work full-time with support from additional staff. As we've learned our lessons around triage and started to think about what's the best opportunity for innovation, recognizing the goals of the MHSA, we put together a proposal here that also recognizes that under the new regulations that the Commission has put into place, we will be receiving information from the counties on the services that they've provided through their innovation agenda. And so the proposal that you have in front of you is really to help us think about 4 significant issues in terms of innovation. The MHSA prioritizes transformation of California's mental health system from something that has really been a fail-first system reacting to crises to one that is prevention-focused and outcome-focused. And so the proposal before you would allow us to build a team of 5 people using 2 positions we currently have and adding 3 additional people to really do 4 things, is to recognize that innovation is a strategic investment in the state of California. Currently, individual counties are often being very strategic within their own counties, but we don't yet have a statewide conversation around the key challenges that are shared across our counties and communities. And so what we're proposing is that this will allow the Commission to really work with the counties and providers in the broad communities to really think about what are the big enduring challenges that are shared and how can we think strategically about an investment that is over a 5-year period, because you can spend these dollars over 5 years, is approaching $500 million. And so we want to really engage the counties and providers around what would those strategic opportunities look like. We also want to improve our ability to do technical assistance and support, particularly as information through the regs is coming in around who's being served and how well they're being served. Third, we need to enhance our ability to do evaluation and monitoring of those investments. And if we want innovations to really drive transformational change, we have to do dissemination. So the proposal before you is to really allow the Commission to build a strategy around thinking better in terms of how we spend the money, supporting the counties succeeding and learning from each other, learning with us, and disseminating that information in ways that innovation really begins to drive continuous improvement throughout California's mental health system.
Anything from the finance? Anything? Questions from the committee? I just wanted to ask one. I understand that the money allocated through the Mental Health Services Act this year, that there are some unspent or underspent dollars, and coming from a community where we're always really struggling to get as much funding as possible to support mental health and Medi-Cal and other programs. I wanted to hear more about, from your view, what's the cause of the unspent or underspent dollars?
Why is there unspent funds?
Yes.
Sure. So there were 2 newspaper stories that looked at San Diego and Orange, I believe, that collectively documented about $350 million in unspent MHSA funds. So we've actually been looking at that. This is why we started to pull down all of the annual revenue and expenditure reports that counties are required to submit, with the goal of being able to answer the question of how much unspent money is there, particularly innovation money. Because the Commission approves innovation plans, we wanted to be able to inform the Commission as part of that review process if a county's bringing a proposal together to spend $5 million, $5 million out of how much, right? How much unspent funds is there? It's actually quite complicated in terms of looking at the financial reports that are available. So in response, what we've done is the Commission has authorized staff to sort of open up a conversation with the HCS and the counties to try to figure that out. Many counties put their financial reports online in real time, so you can look at last year's financial reports. And that's where that conflict between these annual revenue expenditure reports and the local reports gets highlighted. We think there's a couple of reasons, but we have not yet figured that out. And one of the things that the counties have told us is that in some instances that they're withholding some MHSA dollars in anticipation of DHCS auditing their Medi-Cal books. And that process can take 4 to 5 years. And if there's an audit disallowance, in other words, if healthcare services basically does not approve a Medi-Cal billing for a service that happened in a prior year, that the counties would shift payment for that service from Medi-Cal to MHSA. So they're holding back some of those funds in anticipation of future liabilities. We've been told that that's not the whole story, that that doesn't explain all of the money that is available. And so one of the things we're trying to do is sit down with them and say, let's be really clear about how much money you have and you're sitting on and why you're sitting on it. The law requires unspent funds to revert to the state after 3 years. Based on information from healthcare services, no funds have reverted since 2008. So we are scratching our head and saying, how is it that this money is supposed to be reverting back if you don't spend it in 3 years? We know there's unspent funds, but no money has reverted. And we believe that there are some logical reasons for this, particularly the state's efforts to encourage counties to leverage MHSA to draw down Medi-Cal and how that creates a structural challenge because of that 3 to 5 year audit cycle. But we're trying to get a better answer than that.
Anything from the Department of Finance on this subject? So what's your timeline, your estimated timeline to be able to have an answer for this?
Our hope is that we can, at least on the transparency side, 3 to 6 months, even if it's a sort of a patch, even if it's not relying on the financial reports that are provided to the state, if it's working with each county individually, which means there will be some apples to oranges comparison issues. We hope to be able to at least get started, because we know once we release this kind of information that it will create an incentive for the quality of the information to improve. In terms of answering the question about why counties are sitting on funds, that'll have to come next, because we first have to document how much they're sitting on before we can have some honest conversations about why that is. And to be clear, our goal is that under realignment and under the design of MHSA, those are conversations that need to happen locally. And so what the Commission is really trying to do is empower the local communities to have clarity on the decisions that their counties are making, so that that community planning process that's required under the law, so their boards or supervisors are as informed about how much available dollars are out there as they need to be.
We're going to invite you back to this subcommittee to share with us in real time what you're learning. And also, I want to invite you to work with my office in any ways that we can be helpful. Here's why: because we know that the need is great in the communities for community mental health. We know that the surplus does not reflect a lack of need that exists, and we want to figure out how to help align those dollars with the needs that we know exist in the community. We know that the Oversight Commission is doing good work, and so you're welcome here anytime, and we want to work closely with you and the members of the Commission to get clarity about this particular surplus issue.
Thank you. Happy to come back.
Thank you. We're not taking any action on this innovation proposal, but we do welcome any public comment if there's public comment today. Is there any public comment? Thank you, Mr. Ewing.
Thank you.
Seeing none, we're going to move on to issue number 4. The Department of Health Care Services will have a community mental health services overview. Do we have someone from the department here? Oh, Ms. Kent is here. Please come forward. And Karen Baylor, Deputy Director of Mental Health and Substance Abuse Disorder Services. Welcome. We are ready whenever you are.
Good afternoon. So by way of introduction, we wanted to make sure that the committee is both appreciative and aware of the fact that we have, kind of ongoing continued integration efforts within the department itself. So we have, years ago, 2 or 3 years ago, we absorbed both the departments of alcohol and drug programs as well as the community parts of the Department of Mental Health. And, Karen is the deputy director over those shared entities. And I think what you're going to hear from us today by way of overview is both the continued progress that we have been making, both on a federal level with various waivers, as well as our ongoing efforts to further align and integrate behavioral health services into the broader Medi-Cal program and benefit structure. And so with that, we wanted to quickly talk just in high level over the various funding sources, and I'll let Karen kind of talk mostly about the kind of big pieces of funding and streams of work that we've got in line with that.
Sure. Hi, good afternoon. Mental health is funded through 1991 realignment, 2011 realignment, Mental Health Services Act, which you just had conversation on, and with federal financial participation and with some county general funds. SUD, Substance Use Disorders, is funded with Drug Medi-Cal and what's called a Substance Abuse Prevention Block Grant that is from SAMHSA, which is our federal partners, and then whatever county funds. So they're funded by two different systems. What we're working on right now is looking at the 2011 realignment. Base has not been set yet, and so in accordance with regulations, we are meeting with the County Behavioral Health Directors Association, and I never get CSAC right.
California Association, County State Association.
It's okay. CSAC is good enough.
CSAC is
Please
good.
continue.
Thank you. To discuss where we are looking at claims for a year and what the allocation was. As you know, in the 2011 realignment account, there are the entitlements of EPSDT and Drug Medi-Cal. And so we're having conversations. I think we're very close to having an agreement on where we are with base. Once that conversation has completed, we will be looking at growth. I think there's $117 million in growth from 14-15 that we'll need to distribute, and so that is also done in consultation with CSAC, CBHDA, and the Department of Finance. So there is quite a bit of money coming into the system this coming year.
Yeah, no?
Thank you. Anything from Finance here? Any questions from the committee? Seeing no, is there any public comment?
Thank you. Mr. Chairman, Rusty Seelix for the California Council of Behavioral Health Agencies. Just to note that we've had some discussions also with the department about how these funds will be allocated, and we would expect that they would continue to consult with stakeholder groups as well as with the counties in this area.
Thank you. Any other public comment? As you can imagine, whenever there's a surplus in funds, there's going to be wide interest. This committee is interested too. So
absolutely. And we did have a very broad stakeholder meeting in October to discuss some of the initiatives and how we incentivize counties regarding this additional funding. But I'm sure we'll be back again to talk more about what methodology ended up being selected.
Can you talk about how you do engage stakeholders in the conversation? And I'm thinking about, it seems like this happens a lot, where we get to the end of a fiscal year and there aren't enough dollars for all of the needs that exist. And then sometimes like this, there are additional funds. And how do we have the conversation about how we align need with revenue when, regardless of what category it falls in, as long as it's in the big bucket, how do we figure out how to get it allocated for the places where we've had ongoing gaps in terms of community mental health needs?
There are a variety of ways. I think our current email list has over 2,000 folks on it that we try to email out to let them know when a stakeholder meeting occurs. We've invited folks to send us suggestions. We have a website where they can also send us ideas and suggestions. We take all of that, sit down with CBHDA, CSAC, and the Department of Finance and look at all of the ideas and suggestions and try to measure that up with what we see from our federal partners as being priorities, and then what we're also hearing to try and come out. There is never enough money, as you said, to serve the need, but we try and look at what the highest priorities are and where there have been identified gaps in the system.
Thank you. Let's continue with the presentation on to issue 5, Specialty Mental Health Oversight Budget Change Proposal.
So this refers to one of several waivers that we have, at the department. And I think what's notable about this specialty mental health services waiver is that in previous years, the federal government had only given us approval for 2 years at a time. This last waiver approval, they gave us a full 5-year waiver renewal, which I think is both indicative of their interest in what we're doing out here in California, as well as some of the other components of the waiver in terms of oversight and transparency are things that are really, I think, aligning how these mental health plans are treated and aligned in the same way as our Medi-Cal managed care plans. So there's a lot of things that we are having to build for the first time on the mental health side that has not previously existed in terms of data and different kinds of quality metrics and things. So I think that, again, when you talk about from the department at the highest level and the integration of the benefits, the programs may still always be financed and siloed. Counties will always be the ones that will be our partners in terms of delivering specialty mental health services, but how we work with them and how we work with our plans on the Medi-Cal managed care side are starting to look a lot more alike. So this BCP is really further staffing up the workload associated with some of the oversight mechanisms within this new 1915 waiver renewal. So 13 staff and some contract dollars. Some of the contract dollars, I would note to the previous speaker, we have a really extraordinarily hard time recruiting and retaining certain clinical positions, and so in some cases, some of these these dollars are for clinical staff. I don't know if there's anything you want to add.
That's perfect.
Anything from finance? Any questions from the committee? Any public comment? Again, the committee is not taking action. We're holding this item open. We can move on to issue number 6, short-term residential treatment center licensing, AB 403 budget change proposal. Ms. Kent?
So I'm sure
We're keeping you on your toes.
So I'm sure you're aware of the continuing care reform that's happening over in the Department of Social Services. We've been working very closely with the department on how what was formerly known as group homes are going to convert over into STRTPs, short-term residential treatment programs. You're welcome. And so we are asking for 1 staff and 3 limited term, because all of these facilities have to be Medi-Cal certified, and that's going to be a huge workload. This program is set to implement January 1st, 2017, and so as these group home facilities either convert into foster family agencies or into STRTPs, they will need to be certified, and so we are looking for some resources to help with that workload.
Anything from finance? Any questions from the committee? Any public comment on this issue? Seeing none, we will move on to issue 7, foster care training requirements on psychotropic medications, SB 238, budget change proposal.